Brian, let's move up to the forearm and do the distal radius and ulna mobilization with movement to restore supination and or pronation. Okay.
Off we go. Can I start off by saying, I've already mentioned when we have a wrist problem, sometimes the carpal bones are rotated and it would appear that the lower end of the ulna is sticking up in relation to the other or compared with the other side. But sometimes after fractures and injuries, it is in fact positioned dorsally, if you like, on the lower end of the radius. And the correction is to restore the lower end of the ulna ventrally into its right place, and while you're sustaining that correction, get them to carry out supination. Right. Now, how do you do this? First of all, if I just push on that process, it just does that. And that's not changing the relationship between the lower end of the ulna and the radius. So I've got to fixate or stabilise the radius underneath. And to do that, you'll see my fingers are all of equal length. They're located on the ulnar border of the lower end of the radius. If they're located where you take your pulse, all you can do there is, in fact, take the pulse, but it won't help with what we're about to do. So you go right down there, and imagine the ulna beneath here. It can now move forward without this moving forward. You've got the stability. So we turn over, and now we're going to place a thumb, and we can talk about that, on the lower end of the ulna, and the other thumb on top, and these fingers underneath are on the others, and we're going to reposition the lower end of the ulna down.
So really you've got thumbs overlapping thumbs and fingertips overlapping fingertips.
Yes, underneath.
And you're just on the radius with the fingers and the thumb, the ulna with your thumbs.
Yes. Now, I'm using my right thumb, but never have a rule, right thumb for right radius, and you'll see why when we come to deal, right thumb
for the
right side and left thumb for the left, because when we come to do pronation, you'll find that's not the case.
Right.
The thumb to use is critical. If I use my left thumb here and apply a repositioning, not only am I translating that lower end of the ulna ventrally, but I'm compressing it.
Yes, you're pushing it in that
Yeah.
direction.
Now, if you've got pain in this area and you squeeze that joint, you're asking for trouble. Now, if I place my right thumb on that styloid process, these are correct under there, and my other thumb does the actual work, that pushes down on my right thumb, I have now repositioned those bones. Now, I'm going to ask Jules to supinate, and if she does so quickly, watch what happens. I can't run around. When you're repositioned, she must turn slowly, so I can turn her hand round in supination. Now, when you go as far as you can, and there's no pain, at the end of her active range of movement, you will ask Julie to give overpressure. So Julie will now give some overpressure by screwing it. And she did what patients do, and that's completely wrong. She grabbed her hand, and all she did was to screw her wrist bones round.
That's right.
And that's not giving overpressure to the radius and ulna. So there we are. There's the repositioning. Round. Oh, even that's not good enough. Come further. Yes. She's a slow learner, but there we are. There's the overpressure.
Yes.
And I've had absolute miracles through the years. And one of my teachers, as you know, was Pat Black.
Yes.
And Pat did many courses as a student, if you like. She kept coming back, and the reason being that that's all the supination she'd had all her life. She comes along, and after 12 years, we just got it right back. She became an instant...
Within one treatment?
Yes.
Yeah.
She became an instant convert, and now she's one of my teachers.
Now, I noticed that the movement, that the therapist's movement is a little bit tricky. Is it important where they stand? And would you just discuss that, please?
Well, you'll notice I'm proximal to the wrist.
Yes.
If I was this side and repositioning, and she's, well, you have a problem.
Yeah.
All right? So,
yes.
But
say no more.
Julie liked it.
Yeah.
Now, we have just dealt with supination.
So you stand at the side. The therapist's position is at the side for
and proximal
supination.
to the joint. Yep.
That's handy because they both start with S.
Yes.
Good.
and round we go slowly.
Side and supination.
Now, if you try to get pronation here, that becomes almost impossible.
Oh, because you're standing aside. So,
Yes.
so do you change your
So
position?
now I get distal to the joint, I reposition, and the same rules apply. Underneath, you're stabilizing the lower end of the radius on the ulnar side, and I'm using my left thumb now, not the right. For supination, I use my right. For pronation, I'm using my left thumb, so that when I reposition those bones in the wrist, there's no compression.
Yeah.
I'm going to get her to pronate, and she must not take her elbow from her side. And look at her, right up on target, exactly where I want her. It took a bit of doing. Off you go again. Yes. And notice, I'm not letting go.
Right.
I'm
You
sustaining it. We're following all the rules. Pain-free repositioning, pain-free motion, instant result, and hopefully long-lasting.
So, Brian, as you're talking about the distal radius and ulna and working and mobilizing it, changing a positional fault here for supination and pronation, you also use it for another type of condition.
Yes, you do. What we have just done for pronation and for supination, we should also try for wrist movement. Because if that bone's up on that and it's not due to a sort of malpositioning between those two, it looks up because your carpals are rotated. If you reposition here, you'll often find they get wrist extension or flexion with no pain at all, because you've got bones here articulating here, and if there's some rotation and you don't correct it, it can't work.
That could influence it, yes.
Yeah.
So now with the things that we've discussed, we can not only glide the carpals medially
For the wrist.
relative to
Yep.
radius and
Yep.
ulna, but now we might try repositioning the distal radius and ulna and having them extend their wrist. So those are two techniques that can
and the
be
rotations.
tested during our assessment.
Yeah, the first techniques we taught involved moving the carpals
Yes.
on the radius and ulna, and the last technique is dealing with the radius and ulna, moving those
No.
around with movement.
Now, one more thing I'll ask, because it comes up in our classes, is that that always repositioning the distal ulna in a more anterior direction or ventral direction doesn't make sense. It makes sense for when we're starting to restore supination, but it doesn't necessarily make sense when we're trying to restore pronation.
That's right. That, of course, is the biomechanical reasoning you're using, and my reasoning is that if the bones are not where they should be, once they're positioned, those bones will do what they have to do to get pronation and supination, but you've given them the starting position for that to occur.
So you're altering the starting position of the ulna,
Yes.
because if it is too far posterior to begin with pronation, then it cannot go back any further. So we reposition it in a neutral position and then have the patient move, and as she moves, then it can now come back more normally.
Yeah. Can I just make a comment? Julie, one of our teachers, I can't believe this, but she, when teaching this condition, said that so that they don't get it wrong, there's your fixation underneath, the fixation fingers, the thumb of that hand becomes the action,
The
or
mobilizing.
the
hand.
mobilizing.
Yeah. And that makes sense so that you don't compress the joint, as
Yes.
you were just saying before.
So that's another way. Look,
Yes.
I only teach what I teach because I always just see bones there.
Yeah.
I want to put that bone where it should be, and I want to make sure when I do it, I don't squeeze them.
Yeah.
And therefore, I'm not thinking so much. You were thinking logically in another way, which is perfect.
You were also mentioning that if you try to tape this joint, it doesn't work as effectively. Why is that?
Well, to really get that into position and sustain it, because this is a bit more powerful, your forearm, and you'd have to come transversely round. And the moment you introduce a compression of that joint, you're in trouble. And if you come obliquely up the arm, and some people have much more muscle, they're probably good golfers, they have much more muscle than, say, Julie does, it's not stable to anchor it. And we want it to So look, if it works, you use it.
Okay.
That's the rule, and there's no pain. But I've found things happen as we do it, and I get so excited because 2 days later, it's better.
Yeah.
And look at Pat. She's
Yeah.
better years later, and she never lost what we got.
Absolutely.